So today's class will be on the infections in the diabetes. Is one of the very important topic, because we see a lot of the infections in the diabetes, and in fact one of the important causes of the mortality in diabetes is, on one hand we have the vascular events like the myocardial infarction, on the other hand it is all the infections that causes lot of sepsis in diabetic individuals, and finally they die of septic shock. So it's a bidirectional things. So infections will cause more and more hyperglycemia, and hyperglycemia will attract lot of the infections, and finally it is a big vicious cycle. So there is an impaired glycemic control by increasing insulin resistance due to the release of the cytokines and the counter-regulatory hormones. So once there is an hyperglycemia, there is an endothelial dysfunction on one hand. On the other hand, so there will be more and more insulin resistance, and that could be another factor for the entry of the infections in our body. Infection is frequently a precipitating factor for the ketoacidosis. So you know that in Indian population, the most precipitating factor for the ketoacidosis is uncontrolled UTI, uncontrolled RTA, uncontrolled abdominal infections, etc. So some focus in the body will definitely trigger to cause more and more hyperglycemia, and left untreated, so it will lead to ketoacidosis. So these are the predisposing factors for the infections in the diabetes mellitus. So that is the reason diabetes is also considered as a immunocompromised state. So immune system dysfunctions, what are all they? They have the cellular innate immunity, humoral innate immunity, cellular adaptive immunity, and humoral adaptive immunity. So all these things will be involved in causation of the infections in the diabetes individuals. So the cells involved here are the neutrophils and the monocytes are the macrophages in cellular innate immunity. So what the defects you noted in the diabetes in these things is, there will be the reduced neutrophil chemotaxis, adhesion, and phagocytic function. So there will be the neutropenia in some of these patients. So your total count is not, it will be always 20,000 or 30,000 to consider as a sepsis. Even the total count may be 1500 or 500 or 1000 or 2000 to call it as a sepsis. There will be the reduced production of the reactive oxygen species. So there will be the stress, oxidative stress will be there, leading to the impaired killing of the pathogens. Impaired macrophages, monocyte chemotaxis, and the phagocytic function. So all will lead to more and more infections because of the less and less chemotaxis. The T lymphocytes and the monocytes and macrophages are involved in the humoral innate immunity. Here there will be the elevated resting values of the pro-inflammatory cytokines like your tumor necrosis factor, interleukins, etc. So they will be very much elevated. So all these markers will be elevated in the presence of your sepsis, just because of your humoral innate immunity caused by the T lymphocyte activity, and reduced cytokine response to the stimulation. So that is also important to cause the humoral innate immunity abnormalities. And cellular adaptive immunity, the T cells are involved here. The impaired proliferative response to the different stimuli, and impaired delayed hypersensitivity reactions. Now the B lymphocytes and the plasma cells will be involved in the humoral adaptive immunity. They are the normal immunoglobulin response to infection and the vaccinations. So these are the how these cells are defective in the presence of the infections in the diabetes, and how these immunity abnormalities we often see it. That is the reason diabetes means not only a metabolic or endocrine or vascular disease, it is also an inflammatory disease. So what are the predisposing factors for the infections in the diabetes? The secondary factors. So peripheral vascular disease, so there will be the ischemia, there will be hypoxia, so definitely more and more infections. Peripheral neuropathy. So because of the peripheral neuropathy, a trivial injury will cause to the body, to the tip of the feet, etc., fingers, etc., toes. So definitely there will be the entry of the organisms into the body, and they may cause the sepsis, diabetic foot ulcers. A chronic renal failure. So definitely a chronic renal failure, people will have anemia. So definitely anemia will act as a entry of the organisms into the body because of the low oxygenation, cytooxygenation. So the people are the dialysis, so definitely there will be the more and more tubes there. So the catheter tubes or dialysis tubes, etc. So definitely there will be the entry of the organisms into the body, causing more and more infections. And usually the dialysis infections are very, very costly infections. and lot of the nosocomial infections or multiple pathogens may be involved in here, and in spite of your heavy antibiotics also, so most of the people, when they get the sepsis during the dialysis, so definitely that will be the end of their day. And definitely the urinary catheters and intravascular lines, your IV lines or your central lines, so these are all entry of the organisms into the body. So if you do it in the aseptic precautions, so definitely more and more infections will enter into the body. So these are the factors responsible for the entry of the organisms into the body in a diabetic individual. When the blood sugars are very, very high, so definitely even the small bacteria will behave like a very big bacteria in the presence of high sugars. Now the agent specific factors. So high glucose levels stimulate the Candida albicans. So that is the reason some people know they will have the penile candidiasis, vulval candidiasis, or the oral candidiasis in uncontrolled diabetes. These are the very, very common. Sometimes they could be the initial presentation of the diabetes also. So they produce certain complement-like proteins which promote the adhesion of the Candida to the vaginal and the buccal epithelium. Rhizophus produces the ketone reductase which allow them to thrive in the hyperglycemic and acidotic melee found in the DKA. So the Candida albicans and the Rhizophus, these two are the very opportunistic infections, very common in diabetics and also in the HIV positive individuals because of the low immunity levels. Foot infections are very, very common in our diabetics, especially in our rural Indian population, and this is a very common reason to lead to into the amputations. So whenever you see a fellow on with an amputated fellow on the road, there were only two reasons in Indian population. One is the traumatic amputation, the second one is the diabetic amputation. So the common initiating event that results in the limb loss, they don't know that they are going to lose the limb on the day 1 or the day 2, but slowly, so the infection will spread up, but whatever may be the debridements you do it, whatever may be the how much insulin you are using to control the blood sugars, whatever may be the antibiotics you are using it, but they are all useless in some individuals. Finally, they need the amputation. 60% of the lower extremity amputations in subjects with the diabetes are due to the infected foot ulcers. So infected foot ulcer is a very big problem, and very fortunately, they are all preventable causes. So definitely you have to give a lot of advice to the people who are at risk, the foot are at risk. So whose foot are at risk? An uncontrolled diabetic individuals, alcoholics, okay, with the peripheral neuropathy, etc. So the 10 grams monofilament test should be done in all the chronic diabetics individuals to know whether the foot is at risk or not. When the foot is at risk, so the proper footwear is very important, and debridements are very important, detachments are very important. So these are very otherwise, these people are going to lose the limbs, leading to amputations. Here the infections are often the polymicrobial. So that is the reason we use both gram-positive, gram-negative and anaerobic organisms antibiotics whenever you see a foot infections in a diabetic individuals. So in the general hospitals they use ampicillin, they use amikacin, they use metronidazole. So ampicillin will take care of the gram-positive organisms, your gentamicin or amikacin will take care of the gram-negative, and then the anaerobic organisms, metronidazole will take care of it. Whereas in our corporate hospitals, they use the meropenem, or they may use the Tazobac, or they may continue to use the amikacin provided the renal functions are good, and then they use the metronidazole also. So this is how we have to see the antibiotic coverage in all the foot infections with diabetics, because it is always polymicrobial. Not only the gram-positive, gram-negative, but all the bacteria will be there. Diabetic foot infection is a potential emergency, can become a serious in a matter of hours. So evening you may see 1 or 2 blisters on the dorsum of the foot, and after 12 hours or the 24 hours, and there will be a large cellulitis on the foot. So it's a very common, very potential things, as definitely is an emergency. Emergency in reducing your blood sugars, emergency in initiation of your antibiotics, and emergency in using your debridement. That is also very important. Debridement is a wide debridement. More details will be on the others. Okay. So these are the common infections in the diabetes mellitus. So what are the common infections? You all know that urinary tract infections are very common, especially in the women. So cystitis, and then the ascending infections, maybe urethritis, then the cystitis, then the ascending infections, and the pyelonephritis. So these are the very common urinary tract infections. Sometimes we might be subject for the nephrectomy also, provided if that kidney is not working at all. Renal and the perinephric abscesses, so they have to subject for the general surgeon or to the urologist for aspiration of the pus or for the nephrectomies. Respiratory tract infections, yes, all the organisms you know of, whether staphylococcus or streptococcus or Klebsiella or Pseudomonas or Proteus, Microbacillus, etc., they are all very common in the diabetic pneumonia cases. So gram-negative pneumonia, gram-negative sepsis, this is also very common. Lung abscesses are very common. So whatever amount of the antibiotics you give it, they are not of use because of the very thick. That is the reason we have to use the very high doses of the antibiotics. Not maybe a 1 gram monoseph TAD may not be sufficient. You may go for the 2 grams or the 3 grams TAD also. Yes, tuberculosis is a very common. So we are all exposed to the tuberculosis. So Mantoux positivity doesn't mean that the patient is infected with the tuberculosis. So Mantoux will be the positive, and your sputum AFP will be the positive, and then maybe your quantiferon gold may be the positive, and then finally you have to start with intensive management of your anti-TT, ATT with the 4 drugs, and the latter maybe the 4 months or the 6 months or the 7 months or the 9 months, depending on the maintenance dose with your INH and the rifampicin. But it's okay in 80% of the tuberculosis cases. But unfortunately in India, you have the multi-drug resistant or extended drug resistant tuberculosis. That is also very common, where you have to go for the second line of the anti-tuberculosis drugs, and where they are all very costly drugs, and they are all cause a lot of the side effects. They cause a lot of hepato injury, they may cause the renal injury, and finally the patient may die off because of the extensive drug resistant tuberculosis or multi-drug resistant tuberculosis. So this is a very important organism. In diabetic individuals, you can see all types of the tuberculosis. So what are all the tuberculous organisms will enter into the body, you can find in a diabetic individuals, starting from the head to the toe. So these people will have the tuberculous meningitis. Every year I see at least 4 or 5 tuberculous meningitis. Maybe out of them 1 or 2 people are going to die with optic neuritis, etc., hydrocephalus, non-obstructing hydrocephalus, etc. Finally they die off. In the same way, you will have a tuberculosis of the spine, port spine. You will have the tuberculosis of the cervical lymphadenopathy, or axillary lymphadenopathy, or mediastinal lymphadenopathy, or retroperitoneal lymphadenopathies. Then you will have the tuberculosis of your paranasal sinuses, sinusitis. Tuberculosis of because of OT, otitis media, tuberculosis, or tuberculous mastoiditis, or tuberculous pneumonias, then the tuberculous pleural effusions, tuberculous pericardial effusions, tuberculous pericarditis, tuberculous endocarditis, Liebman-Sachs endocarditis, etc., a lot of vegetations, and then the aortic regurgitation, mitral regurgitation, etc., and then you will have the TB abdomen, peritonitis, okay, and then the tuberculosis of the kidney, so renal tuberculosis, tuberculosis of the Salpingian tubes, tubal tuberculosis, and then tuberculosis of the epididymoarthritis. Then finally, tuberculosis of muscles, Ponson's disease. Okay, it's an autoimmune disease reactive to the tuberculosis antigen. So these are the very common diseases we often see day in and the day out. All the diseases I referred to you about the tuberculosis in the organs, all will be seen in uncontrolled diabetic individuals. Then coming to the skin and the soft tissue infections, you have the surgical wound infections. So that is the reason in all the surgery people. So when they have the diabetes, history of the diabetes, they are very much worried about their date of discharge. Usually after the surgery, usually they used to discharge on the 5th day or the 7th day or the 8th day. But in a diabetic individuals, they admit 2 to 3 days earlier to the surgery, prior to the surgery, and keep on them the 4 shots of the insulin, maybe the basal bolus therapy, and then they subject for the as a first case for the surgery, and then post surgery again the insulins, etc. And they are all worrying about the infection. They use a lot of the antibiotics there But in spite of that, lot of the cases will have wound infections, surgical wound infections. Again, we have to send the pus for the culture and sensitivity, wait for the report, and then change the antibiotics, and then keep on changing the antibiotics. Finally, some of the people, they die in the hands of the intensivists with the diagnosis of septic shock following the surgical wound. Okay, so these are all very, very common in our routine practice. Foot infections, I told you, very costly subject. I think the foot infections cost will be more than your CABG, more than your PTCA. So I know some of the people who spend nearly 10 lakhs for their foot infections to save their foot. Abdominal infections like Salmonella, enteritis. So what are all the organs in the abdomen, like Shigella or your Salmonella or Enterobacteriaceae, etc., or Campylobacter jejuni. So they will be multiplied in the presence of uncontrolled diabetes. They will have nausea, vomiting, abdominal cramps, loose motions, etc., dehydration. So one should be very careful about these abdominal infections and treat accordingly. Eye infections. See the stye, hordeolum externum, chalazion, hordeolum internum. Oral infections, periodontitis. So these are also very common. Now the oral infections are also related to your ischemic heart disease. So the more the oral periodontitis, they are more at risk of getting ischemic heart diseases, like your hyperuricemia and microalbuminuria. The oral infections, periodontitis also may be a risk factor for the future vascular diseases. Here the male 25-year-old, a building construction worker, he is undergoing treatment for pulmonary tuberculosis with no family history of the diabetes. BMI 22, so normal is 23, so he is normal, his ideal body weight, and blood pressure is also normal. So does this patient require screening for the diabetes? So in India, all the tuberculous people should be screened for the diabetes. And all the diabetic individuals, when they are complaining of the respiratory symptoms, more than 1 week or more than 10 days or more than 15 days, with evening range of temperature, some cough, some breathlessness, some sputum production, so definitely you have to get a X-ray done or maybe other investigations to rule out the tuberculosis. So all the tuberculosis individuals rule out the diabetes. All the diabetic individuals with respiratory symptoms more than one week or more than 15 days or more than 1 month should be rule out tuberculosis. So it's up to 14% of the patients with the tuberculosis have the diabetes, very high number. Diabetes patients have a relative risk of tuberculosis. 5 to 30% of the patients with the diabetes have tuberculosis. So they depend on the places they live with. When they are living in the remote areas, so there may be chances of getting the tuberculosis very rare. But when they are living in Rajahmundry or Kakinada or in Amalapuram or in Gudivada, Vijayawada, so definitely the chances are very high. Especially nowadays, RTC buses, free buses, very busy. Very busy. Magal got to seat lever. Very busy. Peculiarities of the tuberculosis in the diabetic patients. See, these all are separate. More likely to have a pulmonary rather than the extrapulmonary tuberculosis. Whether there is pulmonary or extrapulmonary, very common in the tuberculosis individuals. Relative paucity of the physical signs leading to the delayed diagnosis. Usually the signs will be very few and the symptoms are also very few. So that is the reason we don't think of tuberculosis in those individuals, and by the time you diagnose it, it is already late. Yesterday I have seen one patient, 3 months back he came to me, a diabetic with some cough and breathlessness, etc. and fever. I have given him antibiotic and he was all right. Yesterday he came again with an history of again recurrent fever and cough and the breathlessness. I took an X-ray and 3 months ago I didn't take an X-ray, but now I have taken X-ray, a beautiful cavity, open cavity in the left upper lobe. See, tuberculosis. But the problem is, he is an open case. So he has been transmitting the disease for the last 2 months or the 3 months to the public. So it's a very common. Extensive caseation and the cavitation, they are very common. More likely to be sputum positive, So this is very important, whether he is positive or the not. So sputum positivity means it's the open cases. So their all spread is very high, and they spread the disease very commonly when compared to the extrapulmonary tuberculosis. So the person is living with the cervical lymphadenopathy or the pleural effusions or pericardial effusions, nothing to worry. Even you diagnose it at a later time, they are not the open cases to spread the disease to the other population. But the pulmonary tuberculosis, especially the upper lobes, cavities, so they are very dangerous population. Minimal pleural involvement, delayed sputum smear clearance. So the non-diabetics, if you start the ATT, so you see the AFB positivity after 15 days or the 20 days or the 1 month, negative. Initially they are positive, non-diabetics, and once you start on the ATT, after 10 days or the 15 days, the sputum positivity will be negative. But in diabetic individuals, even after 15 days of your ATT, even after 1 month of the ATT, even after the 2 months of the ATT, still the sputum was positive. So this again is a big problem in Indian population. That is the reason eradication of the tuberculosis is is not possible in India because of the presence of the diabetes in India. So if you want to eradicate the tuberculosis, you have to reduce the incidence of the diabetes also. But with this high calorie diets or jamota, samota, etc., and the 3 AM biryanis, etc., it's very difficult to control diabetes. Once you are not able to reduce the incidence of the diabetes, and obviously you can't eradicate the tuberculosis or any other infections. Treatment failure, relapse, reinfections are very common. And most of my rural individuals know they don't take the ATT for the 6 months. Even by say day 1, see, you are having the fever, you are having the cough, you are having the breathlessness, your sputum is positivity, and your X-rays are abnormal, your CT is abnormal, now you are losing the weight, the diagnosis of tuberculosis is fine. We got the diagnosis. We have a beautiful drugs to treat it, whether the first line of the drugs or the second line of the drugs, whatever may be the matter. I am damn sure that you are becoming asymptomatic in a span of 15 days to 1 month. Your fever will reduce, your cough will reduce, your dyspnea will reduce, your sputum will be negative, everything will be negative after 15 days or 20 days or 1 month of the ATT. But you have to continue the medication for the next 5 months or the total 6 months or total 8 months. Okay. Insulin is the drug of choice, of course, I told you, at least for the first 2 months of the ATT, your intensive phase. If they take the 6 months or the 9 months insulin, I will be very happy because the sugars will very good control with your insulin therapy. But again here, most of the people know you start insulin therapy, they don't take the insulins. They don't take the OHS also, they take only ATT. So what will happen? The sugars will go up, the tuberculosis bacilli may die, but they will land up with DKA. So that is also there. So that is the reason you have double duty. One is to reduce the tuberculosis epidemiology by addressing them about the utility of the ATT. On the other hand, we have to tell the importance of the insulin therapy in a tuberculosis individual, at least in the first intensive phase. So I don't start any OHS in the first initial phase of 2 months. I always give them insulin therapy. I write it on the case sheet that insulin is the drug of choice at this juncture. Don't dare to change to OHA. So rapid improvement in the glycemic control with your insulin therapy. So definitely your QB control also will be good. Helps in correcting the cachexia associated with the tuberculosis. So insulin is an anabolic hormone. They gain weight gain. They increases the appetite. So these are all will good. And helps in healing the process. Your cavitation, your caseation, your fibrosis, everything will be reduced very fast with your insulin therapy. OADs can interact with the anti-tuberculous drugs, especially rifampicin, and should be used only in the mild hyperglycemia, maybe after the 3 months or the 4 months or the 6 months. INH can worsen the peripheral neuropathy, that you all know that. So side effects you should know of. INH, peripheral neuropathy, rifampicin, hepatitis, ethambutol, optic atrophy, pyrazinamide, hyperuricemia and arthralgias. So what the fellow is on the ATT, so whenever he complains of these things, so definitely attribute to the drugs. Tight glycemic control is essential for success of anti-tuberculous therapy. Now HIV and the diabetes. Again, the world capital, international capital of HIV is again India. Diabetes is not considered a risk factor for the HIV infection. People living with HIV or the AIDS are more likely to have the type 2 diabetes compared to those without the HIV infection. So those people with HIV infection, so you will have more and more insulin resistance. And obviously they are on the drugs. Okay, the 2 drugs or the 3 drugs, etc. So the antiretroviral therapy, heart. So once the people are on the heart therapy, so definitely they cause more and more incidence of the diabetes because of the insulin resistance. Drugs used in a highly active antiretroviral therapy, heart, can predispose to the development of the diabetes. Both protease inhibitors and nucleoside reverse transcriptase inhibitors, NRTI, have been implicated here. Protease inhibitors affect both insulin secretion as well as the sensitivity. NRTS produce diabetes by affecting the insulin sensitivity as well as the lipodystrophy and mitochondrial dysfunction. The strongest association is with stupidin. Other drugs used to treat the comorbidities like pentamidine can also predispose to the diabetes. Incidence of iatrogenic diabetes in HIV patients has been assessed to be as high as 5.72 per 1,000 person years follow-up. Insulin is the treatment of choice in heart-induced diabetes. So in a single word, diabetes and HIV is a very common combination. The people with a strong family history who are on heart therapy, they are at high risk of getting the diabetes very soon because of the insulin resistance, because of the reduced insulin sensitivity, or because of the strong family history of the diabetes. Again, in all these people, the insulin is the drug of choice because of the anabolic nature, improves the appetite, improves the body weight, etc. And once you use the OHS along with the heart, so there will be the drug-drug interactions and more chances of having the hepatotoxicity and the renal toxicity. So we all faced this epidemic, a dreaded epidemic so far, COVID-19. So crores of the people have died because of the COVID-19 infection. So diabetes does not increase the risk of contracting the COVID-19, but individuals with the COVID-19 have an increased risk of adverse outcomes of the COVID, such as the severe disease, ICU admissions, and need for assisted ventilation and the death. So we have seen that COVID-19 and the comorbidities. So in uncontrolled diabetes, they got the COVID-19 and they need the oxygen saturations are coming down. Then they need the ICU admissions, on the second or third day they are going to die. So the most of the deaths in the COVID-19 ICUs are either diabetics or hypertensives or IHD population or CKD population or elderly population or people with COVID, people with HIV, people with tuberculosis, etc. etc. So the diabetes is a very important disease. Now COVID, even the COVID-19, now the COVID is there in every year. So that will be there in our Indian population. COVID-19, COVID-25, COVID-26, COVID-27. So that will be there till 3039. The poor outcomes may be partly due to the comorbidities such as the advanced age, obesity, hypertension, and the CVD that are more common in the COVID-19 patients with diabetes than those without the diabetes. Poor glycemic control at admission and during the hospital stay, as well as admission HbA1c are independent predictors of the outcome. So some people know pre-diabetics with the COVID-19, they turned as the diabetics after the COVID-19 treatment because they have used a lot of the steroids. So because of steroid therapy, so the blood sugars have gone up and definitely they are with diabetes. So what is the onset of the diabetes? After COVID. Very common reply. Okay, what is the duration of the diabetes? 3 years, sir. When you got the diabetes? When I got the COVID. After the COVID, I was diagnosed as a diabetic. But during the COVID, diagnosed as a diabetes. COVID-19 has also been associated with the new onset diabetes, hyperglycemia and worsening of the existing diabetes. So again the control, so it's a rule, whenever the patient is in the ICUs, your target should be between 140 to 180. So more than 180 blood sugar, start with insulin, less than 140, stop insulin. between 140 and 180, continue the insulin, same dose. Oral anti-diabetic drugs can be used if not contraindicated in mild COVID and if hyperglycemia is not severe. In all other situations, insulin should be initiated. So guidelines on the use of the oral hypoglycemic agents. Prescribed oral GLPs, no contraindications for the oral glucose lowering agents, a mild COVID, mild hyperglycemia. DP4 inhibitors are very useful drugs to be used. Not your sulfonylureas, not your metformin, not your pioglitazone, not your voglibose, and not your SGLT inhibitors also. So the only drugs we prescribed OHS during our COVID period is your DP4 inhibitors. And of course, insulin. You know how much insulin you have to use it, maybe 0.1 unit per kg body weight or 0.2 units at 0.4 units depending on the obesity, depending on the insulin sensitivity and the resistance. So steroid induced hyperglycemia. So this is the very common. Now the rare infections predominantly associated with the diabetes mellitus. So it's a very specific for a diabetic individuals. So the malignant arteritis externa. So this is not a malignant condition. Rhinocerebral mucormycosis. Very common, especially in the COVID era. We have seen they lost one eye. Okay. So enucleation of the eye is very common with your rhinocerebral mucormycosis. Emphysematous cholecystitis, pyelonephritis, cystitis, necrotizing fasciitis, total muscles are damaged, necrosed, and foreigners gangrene. So these are the very specific and the rare infections predominantly associated with the diabetes. So once you see the foreigners gangrene, so definitely you have to rule out the diabetes. Once you see the necrotizing fasciitis, whether there is no history of the diabetes, also you have to ask the sister to get the blood sugar done immediately. So these are very common infections and very special infections and left untreated with lot of morbidity and the mortality also. He is a 65-year-old male taking treatment for diabetes for the last 16 years. One day he comes to you with the complaints of severe left ear pain and ear discharge. So there is a 7th cranial nerve palsy on the left side. Fasting 235, PP 357 and total count 28,000. Pus culture from ear discharge is positive for Pseudomonas. So what is our diagnosis? So it's a malignant arteritis externa. How will you manage this patient? So treat the diabetes aggressively with insulin and anti-pseudomonal antibiotics. So what are the anti-pseudomonas antibiotics? Linezolid, ceftazidime, okay, 3rd generation, 4th generation cephalosporins, etc. So what is the prognosis? Guarded, not good, okay, guarded prognosis. So why he got the malignant arteritis externa? Because of high blood sugars, fasting 200 plus, postprandial 300 plus, etc. So keep all our diabetics with target blood sugars. So you cannot invite infections. Once they get the malignant arteritis externa, the prognosis is guarded, poor. Pseudomonal infection of the external acoustic meatus and the skull also, skull base, found in elderly with diabetes, severe pain, discharge and features of the facial palsy, aggressive debridement and the anti-pseudomonal antibiotics, high mortality. Now another case, 45-year-old male, diabetes of last 5 years. So he got the diabetes at the age of 40 years. He is on glimepiride 1 mg plus metformin 500 mg twice a day. Okay, typical GSL prescription. Okay, Jammer 1 mg BD. Recently contracted COVID-19 and was hospitalized, at which time he was administered IV dexamethasone for 10 days. 1 week after the discharge, had headache, fever and anorexia. There was swelling over the eyes, proptosis, more prominent on the left side. Unable to open the left eye since morning on the day of the visit to the doctor. On examination, nasal cavity, a black discharge was found with eschar over the left inferior nasal turbinate. Random blood sugar 450, A1C 11.4. See the history of the patient. He got the diabetes at the age of 40 years. Now he is 45-year-old. He is on Jammer 1 mg twice a day. The sugars are relatively under good control till he got the COVID-19. So he contracted COVID-19 and he was hospitalized and then given Decadron, injection Decadron for 10 days. And he discharged. He didn't require any oxygenation or any ventilator support or etc. After the discharge, he got very few complaints, headache, fever. Now the nasal cavity is bad, okay, and there is eyeball abnormalities. So what is our diagnosis? What is the working diagnosis? Very big diagnosis, very big diagnosis, life-threatening diagnosis, life-threatening diagnosis, okay. And how will you manage this patient? So multidisciplinary actions, at a physician alone, okay, get a CT scan done, get an MRI done, see the neurosurgeon, see the ophthalmologist, okay, see the ENT surgeon, okay, debridements, a good theatre, and finally maybe enucleation of the eye also is possible. So what is the prognosis? See, that is the reason as a postgraduates we have a very high role to play not to have the infections in our diabetic individuals. Rhinocerebral mucormycosis. Infection of the nasal cavity and orbit by fungi of the genera Epsida, Rhizopus and the myocard. So the fungal infections found in debilitated patients, especially those with the ketoacidosis. Increased incidence found among the individuals with the COVID-19 infection, particularly treated with the glucocorticoids. Presence with fever, pain, extraocular muscle palsy, proptosis and chemosis. Black eschar seen over the nasal turbinate is a characteristic feature. Venous sinus thrombosis and brain abscess are the common complications. Surgery, amphotericin B and posaconazole, so there is antifungal agents are the treatment of the choice. And high mortality even if treated. So now the necrotizing fasciitis is the common sites of the abdomen, perineum and extremities. Presence with the pain and other local signs of the inflammation. Initially spares the skin and the muscle. Infection of the soft tissues caused by the streptococci, staphylo and anaerobes. The three types, type 1 is polymicrobial, type 2 group A streptococci, type 3 clostridial myonecrosis, gas gangrenes. So the diagnosis culture from the necrotic center of the lesion and treatment, debridement and the surgery, broad spectrum antibiotics. So again this is a very big problem, necrotizing fasciitis. All the muscles will be burned out, lot of necrosis, and you have to get the culture and sensitivity and then the debridement and good antibiotics and again control of the blood sugars with intensive insulin therapy. Foreigners gangrene, so sometimes we see it. It's all the necrotizing fasciitis of the perineum, scrotum and the penis. All that area is necrotized. Causative agents E. coli, bacteroids, strepto, staphylo, pseudomonas and the proteus. There is the extensive scrotal pain and scrotal swelling with the systemic toxicity. So fever, high grade fever, chills and rigors, etc. Sloughing of the scrotal skin, shameful exposure of the testis and the spermatic cord. Surgical emergency. So treatment, unroofing of the lesion, broad spectrum antibiotics, architectomy may be needed, not rarely, most of the times they do architectomy in the Farner's gangrene because almost all exposed to the testis and the spermatic cord. Again the mortality will be very high. Again the treatment here, intensive control of the diabetes provided the patient is a diabetic. So don't allow any of your diabetics blood sugar more than 180. Another case, a female, 46 years, type 2 diabetes on OHS, fever for the last 3 days with vomitings, abdominal pain and dysuria. So the diabetic, abdominal pain, vomitings and dysuria. So clinical examination, patient is very toxic, febrile, dehydrated, severe tenderness over the left renal angle. Urine shows plenty of the pus cells and pus casts. Urine for acetone is negative, ketone bodies are negative. Fasting 260, urea 52, creatinine 1.4. So the urea and creatinine is going up. There is a lot of pus cells in the urine, bacteria are positive and pain in the lower region, left renal angle is tenderness. So what is your WBC? 38,000. So what is your provisional diagnosis? It is no more a urethritis, no more a cystitis, already ascending infection, kidneys involved. Okay, so pyelonephritis. Again emergency, it's a big emergency. See the counts, 38,000. See the urea and creatinine. So almost acute kidney injury because of the infections. So you have to treat accordingly. So give high amount of the antibiotics, very good antibiotics, which covers these organisms. Mostly urinary tract infections means E. coli, etc. So you have to give the more specific antibiotics here. So and then insulin, IV fluids, definitely. Now the emphysematous pyelonephritis, this is necrotizing infection of the renal parenchyma and the surrounding tissue. Almost exclusively found in patients with the diabetes. Females are more common. E. coli and Klebsiella. Gas is formed with the fermentation of the glucose. If you take an X-ray now, so there will be gas around that perinephric fat area will be seen. Radiological demonstration of the gas. Management antibiotics, percutaneous drainage of the pus and sometimes nephrectomy. Unfortunately, we have to sacrifice the kidney. Effects of infection on the diabetes, glycemic control tends to deteriorate during the infection. Patients on insulin may need to increase their dosages. So don't bother about the number of the units of the insulin you are giving it. You please bother about the blood sugar values. Whether the patient is getting 40 units or 45 units or 50 units, don't bother it. Some of my patients, they take fasting before breakfast now 60 units, before lunch 80 units, before dinner 50 units, at bedtime 80 units or 100 units of the basal insulin. So per day, there are some patients, they take 200 to 250 units a day. With that amount of the units of the blood sugar, insulin, their fasting blood sugar is 90 or 100 and post-mortem blood sugar will be 140 or 150. So don't bother about the units of the insulin you are injecting to the patient, but please bother about the fasting blood sugar, PP blood sugar before the lunch, blood sugar before the dinner, etc. So to reach those levels, so whatever may be the amount of insulin they require, you use it, otherwise these people will end up with acute pyelonephritis or emphysematous pyelonephritis, etc. And you may lose the kidneys and the liver and the brain, etc. Vaccination is a very good subject, adult vaccination. So very, very important, the diabetes individuals. Your hepatitis vaccination, H influenza vaccination, your pneumococcal vaccination, your shingles vaccination. Okay, so these are the important vaccinations. So individuals with diabetes should be educated about administering at least pneumococcal and influenza vaccinations. Influenza once in a year, pneumococcal maybe once in 3 years or once in 5 years. 13-valent pneumococcal conjugate vaccine, PCV13, is recommended for children below 2 years of the age. Patients with diabetes age 2 up to 64 should receive 23 valent pneumococcal polysaccharide vaccine PPSV 23. At age 65 years and above, additional dose of PPSV 23 is also recommended. So the two dosages when the fellow is aged about the 65 years are a single dose between the 2 to 64 of the years age group. Annual vaccination with the quadrivalent influenza vaccine is recommended for individuals with diabetes aged above 6 months. Other vaccines, hepatitis B, herpes, or now the HPV, they can be considered based on the individual risk. So these are very important vaccinations. Those people who can afford, so definitely you have to advise the vaccinations. Of course, COVID-19 vaccination is the priority group for the COVID-19. All the currently available vaccines against COVID-19 are safe for use. No need to wait for the good control of the blood glucose before the vaccination. For any vaccination, so in spite of the very high blood sugars also you can give the vaccination. Thank you.